online event today at this extraordinarily challenging time. I'm Dr. Cheryl Healton, Dean of the School of Global Public Health at New York University. I'd like to begin by thanking our colleagues and partners at NYU Washington, D.C. and DC Dialogues, including Operations Manager Coco Hua, who is listening in from her home in China. Preparing for a global public health pandemic through research and training is obviously quite different from responding to and living through one in real time. We can't overstate the gravity of the challenges that lie ahead. As of this morning, over 392,780 people around the world have tested positive for COVID-19, and an estimated 17,156 have lost their lives. Yesterday, it was suggested during a White House briefing that the impact on the health of the COVID social distancing approach may exceed the impact of the effects of the strategy on the economy by costing more lives. This is exceedingly unlikely, given the estimated mortality of the epidemic and its trajectory without such measures. Indeed, without interventions, the death toll could come close to the number of deaths due to all causes of US mortality for an entire year. I am grateful to four of our faculty at NYU GPH who are with us today to bring their expertise to this evolving crisis. This discussion will be led by award-winning journalist and author, TV contributor, and USA Today healthcare policy reporter, Jayne O'Donnell. Thank you, Jayne, for your terrific work keeping the nation informed on the coronavirus and taking time from your busy schedule to join us today. Let's get to it. I'd like to welcome Dr. David Abramson, Clinical Associate Professor of Social and Behavioral Sciences and Director of the NYU GPH Research Program on Population Impact, Recovery and Resilience, Dr. Jack Caravanos, Clinical Professor of Environmental Public Health Sciences, and as a certified industrial hygienist, an expert on personal protective equipment, or PPE, Dr. Robyn Gershon, a clinical professor of epidemiology and interdisciplinary environmental health and safety researcher with extensive experience in the areas of disaster preparedness, healthcare safety, risk assessment, and management in high-risk work occupations, and Dr. Elodie Ghedin, professor of epidemiology and molecular parasitology and virologist. Her lab at NYU explores influenza virus diversity in the infected host and the respiratory tract microbiome to better understand transmission dynamics. Thanks to each of you for taking part in this afternoon. And I'd now like to turn the program over to Jayne O'Donnell, who, in addition to her role at USA Today, is co-founder of New Urban Health Media Project, training high school students in Washington, D.C. and Baltimore, Maryland, to respond to health and social issues. Jayne?
Thank you so much, Cheryl. It's a pleasure to be here today. And it's kind of a funny thing to even say it's a pleasure to be here, but we're talking about all of the issues that in the seven or so years I've covered healthcare, that is, that always interested me the most. So public health and the underlying conditions that lead to disparities is what I prefer to cover, and this is certainly not the situation I'd want to cover it in. Patient safety as well, and it's what I'm spending my time on the weekends working with young people to do. And I honestly think having gotten into journalism in part because of Watergate, and also seeing what happened after 9/11 with all the interest that brought to terrorism and national security, that maybe we'll finally get the this beat and subject area all of you are working on will finally get the attention it deserves. I'd like to start with Elodie, if I can. Excuse me. It's a criticism. Excuse me. Frequently, I have nothing. I'm not sick. It's a criticism frequently of the media that we focus on the negative, and that can have a very, it accentuates in this kind of situation that, you focus on a person died or a person is near death, but do we really have any idea, Elodie, like how that fits in, like how many people are getting tested? I mean, we don't write about the people that are not having hardly any symptoms or haven't been tested, or have been tested and don't have coronavirus. Elodie?
Yeah, that's a great question, Jayne. As we see the numbers rising, we're never given the actual denominator, meaning how many people are actually being tested all the time. So all we're seeing is that the numbers are rising, especially in New York City. But then if we compare to the actual number of tests that have been performed, there are far more in New York State than there have been in other states. Now, in one sense, it gives the impression that there is really a focus here and an important outbreak in New York, which may be true because we are one of the biggest cities, high density, so there is high transmission. But at the same time, there may be very similar transmission in other parts of the US, but we have no idea. We're not reporting the negative tests. We were initially, now we're not. Every state is doing things differently. We know of many stories of people who have all the symptoms and even could be healthcare workers and cannot get tested. So there's really a difference in how we can predict what is going on. And we don't know how well the distancing that we're doing is going. And if we don't know whether the social distancing is helping with transmission, we can't stop doing the social distancing because it's important to know whether we're having rampant transmission still, whether many of the asymptomatics are still transmitting to others or not. We have no idea. We often hear this expression, but it's so true. We are flying completely blind.
And I just want to follow up quickly because, of course, the president suggested last night, that perhaps we should start easing some of the business-related measures that are leading to or mandating social distancing because of what you just said. Is it too early to suggest that?
It's way too early to suggest that. If we can ramp up testing and test people who have no symptoms, we would have a much better idea of how prevalent it is and what actually is the attack rate in the population. We don't know. We're only testing people who are inpatient. So now is that we can only test inpatient or healthcare workers with symptoms. That's it. So we don't know.
And I'd like to just go quickly now, partly because it's my favorite subject, really, to David Abramson. So this epidemic has really underscored, exacerbated, put into stark relief so many of the issues that haven't gotten attention for so long, the social determinants of poor health and low-income communities. So could you talk a little bit about what groups are more vulnerable now? And is there even any data? A colleague of mine just asked me yesterday, is there any breakdown on race when it comes to these diagnoses yet? And how soon will it be, or how long will it take, do you think, before we have that, if not?
Right. Thanks for the question, Jane. And I think when we start to think about vulnerability, it's interesting because a lot of the discussion so far has been about vulnerability to the virus itself. And we've obviously characterized vulnerable groups in terms of healthcare workers, seniors, people with chronic health conditions or immunosuppressed conditions. And so that's a vulnerability to the virus. But what we haven't really thought about as much is vulnerability to the consequences of various containment and suppression strategies. And this in some ways is like many disasters. If you think about a hurricane or an earthquake where you could be exposed to the initial event itself and then you have an evacuation and a displacement, it's that secondary effect of the evacuation and displacement that really exacerbates a lot of the vulnerabilities. And so there are quite a few vulnerable populations, and as you pointed out, one framework that we use to think about this are the social determinants of health. But if you think about people who are socially marginalized or disenfranchised in some way, so you might think of people who are undocumented or people who are poor, people who are socially isolated, people who are homeless. These are all people that exist not in essentially the mainstream or are concerned about engaging with institutions, particularly with institutions that may be security-related institutions because they're concerned about their own status. And once you have that going on, you've got the potential for a viral reservoir to continue in the population and continue transmitting a virus because we're not regarding everybody as equal. In order for this to be an effective strategy, this requires maximal equity. We have to think about equity of susceptibility, essentially. We are all susceptible. And by saying that we are all susceptible, it means we are equally all vulnerable. And so that's sort of an essential question. In terms of the racial differences, I think it is too early to know what those sort of data look like. And I haven't seen any reports to date about group differences among those who are hospitalized or who have died. I think that is to come. And unfortunately, it's going to take a little while before we see those things.
I do worry. I was just thinking about how so many, at least where I live, and I suspect in New York City, I'm right outside Washington, D.C., so many of the healthcare workers are of color and lower income in some of the positions. So I can only imagine that they're increasingly vulnerable for so many reasons. And they're at hospital, and they're working at hospitals that have DNF ratings, but we won't have to get into that right now. Let's turn to the equipment issue. I published something over the last couple of days on all of the hospitals still doing elective surgeries. I'm getting emails perhaps every hour from people working in hospitals telling me that, anonymously, that how concerned they are that they are already short of some of the equipment I want to ask about next. Yet there are the surgeons who are insisting to continue to do joint replacements and other types of procedures like that. I wanted to ask Robyn first. I'm not sure, I know the one of the health systems around Buffalo was very late to get elective surgeries, but around New York City, they are struggling to meet the demand for personal protective equipment. What are the reasons for that? Do you think they might have waited too long to stop doing these unnecessary procedures? And what other factors do you think caused that?
I mean, the elective procedures, and thank you for that question, Jane, that's one issue, but our main issue, the main driver of this is that we did not have adequate supplies in the national strategic stockpile. Now, a lot of the people out there, especially my students, a shout out to all the global disaster students in there today, they know about the national strategic stockpile, which is a wonderful resource that the US has developed over the years. Unfortunately, after the 2009-10 H1N1 pandemic, they did not replenish it. They did not keep it up, and they did not even, exceed whatever they had. So we only had about 12 million N95s in that stockpile, of which 5,000 had outdated. The outdated part is the elastic piece that goes around the ears. And we only had 30 million surgical masks, just the regular surgical masks. We had a shortage at that time. And even when hospitals, such as out in Washington State, were requesting release from their national stockpile, it was very late to come. I just read that certain states, however, put in their request and got exactly what they wanted within days. For instance, Florida is one of the states, several out in the West. But New York has been asking desperately for this equipment for weeks because our Governor Cuomo has been very much on top of the epidemic in New York City. He asked for and finally got 1 million of those masks yesterday. But I have firsthand intel from a lot of my friends, colleagues, even family members in New York City hospitals that are telling me not only are they being given one surgical mask as they enter the door to keep for the entire 8 or 10-hour shift, that same mask, but more importantly for some of them, they're completely out of the disinfectant wipes, out of the canisters. Some of them had some at home and they're bringing them to use on their floors, but that's totally unacceptable. So yes, we should cut out the electives. I was disturbed to see a couple of states now have said abortions should be considered elective and they have to stop immediately. That's a time-sensitive procedure, of course. But the issue right now is getting these supplies. Now there's a wonderful crowdsourcing group called Project N95. Just some techies got together. They're trying to address the chain, this terrible supply chain bottlenecks that we have in the US. And they're trying to match people with supplies, companies with supplies, with hospitals that need it. We'll see how it goes. They said they had over 100 million requests as of last night. We're trying to do everything we can, but we must protect these healthcare workers. I know Jack can speak very acutely on this issue as well.
Yeah, and I was going to turn to, thank you so much. I was going to turn to Jack. Let's start with the N95 masks. I've heard that a lot of people, or I've read, and I'm sure you folks have as well, that doctors and other medical professionals are wearing them for an entire week. But Jack, can they also expire? And you know, there's always expiration dates. Sometimes can be a little fuzzy. There's a gray area. But how serious is that, and how big a part of the problem with the shortage could that be?
Yes, yes. And you heard from Robyn that they do indeed have an expiration date. That's probably shocking to many people. And it is the rubber bands that may oxidize and fail in the future. I think now there are some exemptions to allow expired respirators to be used. I realized during Hurricane Sandy, we had that where people were sending their stockpiles of expired respirators and they worked fine. And I think we have to go to the CDC guidance. In 2018, CDC issued some guidelines on extended use of respirators N95s for healthcare professionals and what's called reuse. But extended use and reuse come with procedures. So these healthcare professionals have to be trained to take on and off N95s without touching the outside at all, and then proper storing of the N95s. So I think perhaps we have situations where you're given a respirator and then you have to dispose of it rather quickly. And had these workers been told or informed and trained on how to reuse them safely, it will definitely last longer. And also we do have this confusion, surgical masks versus N95s. And what does N95 really mean? And I think most of us in the field acknowledge that it's a large aerosol that's hitting the mask, and whether it's N95 or surgical, so long as it's fitted properly on your face, it'll offer adequate protection, more than adequate protection. So that's hopeful there.
Just a follow up to that, Jack. And by the way, I think your backdrop gets the award for the best backdrop.
Yes.
Oh, thank you.
So if you could just kind of go over that a little bit more, Jack, for like the average person, because I do think so many people aren't sure exactly what they're worried about. I hope we're going to get to talk, maybe we'll have time to talk about the issue of whether you truly have to stay in your house versus go outside. And I had a doctor just a few days ago tell me something that I'm got confirmed by every important person I thought I could, that it is okay for me to be outside walking and but if I jogged or you know, doing yoga in the back, you know, in a field somewhere, if I wanted to, with a group of people 6 feet apart. I mean, Jack, do you believe that those kinds of things are safe if you're 6 feet away from another person? And what are the, you know, is there a transmission if it isn't in a what do you call it, droplets? Is it only respiratory droplets we're worried about?
It is, and I think you have to be fairly close to the individual. Being inside, of course, exacerbates everything. But just the other day, I was walking down the street and a person literally walked into the street, from the curb into the street, ongoing traffic, to sort of go away from me as if I had the plague or leprosy or something. And I looked at them and I said, what are you doing? It was an unsafe act, and they're wearing a mask. And I think very often that's unnecessary. There's plenty of air circulating outside. There's no halo of viruses surrounding an infected person as they're walking outside. And clearly, if you're not infected, the probability is very low. But let's get real. People are scared. They feel they have no control, and they want to act. So I tell people, yes, if wearing gloves, putting on a mask outside makes you feel safer and more comfortable and allows for you to go outside, go ahead and do it. But generally, most respirators I see outside, very few people, I'd say no one needs them, unless of course you're sick and you're trying to keep that, contain that virus inside your breathing zone.
When you say gloves, I think about the big problem there's the pre-existing problem in hospitals where they don't wash their hands enough. Now, yeah, they're wearing gloves, but they have to take them off, get new gloves. And then, so if you're wearing gloves, you're still touching the things, and then you could be touching your face with the virus on your gloves, right?
Yeah, no, you're so right about that. It's the most frustrating behavior I see is people wearing gloves. And I'll ask the person, by the way, why are you wearing gloves? They sort of look puzzled. They don't have a good answer. They say, well, to protect myself. Meanwhile, they're handling the groceries, unpacking bottles, handling my money, etc. And of course, it's on the gloves, and if they touch their face. So I think it's a false sense of security here. It does drive me crazy. I'd rather they have a bottle of disinfectant and they're using it between patrons as opposed to just putting gloves on. But again, sometimes it's a sense of control. They just want to do something to feel safer.
Or if they're like really cute gloves and you're just wearing them for nothing. But I think there's a story in that, like we could do something, photo gallery of all the people out there wearing gloves. If I could come back to Elodie for a moment. If we could shift a little bit to just how quickly you think the virus is evolving, and are there new strains emerging? And also, if it's possible at all, is there any, I mean, every now and then I do see or hear about, and I'm writing about a potential sign of hope that there does seem to be some declines in the fevers being detected around the country. Any signs of hope, and how would you say the virus is evolving?
All right, well, the virus is not evolving quickly at all. It's a fallacy. There are a lot of wrong information out there about that. There has been a paper that was published on the fact that there are two co-circulating strains, and they had said that one of the strains was more aggressive, which is actually not a virology term. A virus is not aggressive. It's either virulent or not, more virulent or less virulent. But in fact, this is a virus that's special in the sense that it actually has a lower mutation rate than influenza. So it doesn't mutate as quickly as influenza. It has the capacity to do what's called error correction. So viruses mutate very quickly, more quickly than bacteria, for example. But most viruses, because they want to adapt quickly, make errors on purpose and don't correct for those errors. And errors are mutations. But coronavirus actually corrects some of those errors. So it's, in fact, a little bit more stable than something like influenza. And so we do see different strains emerging, but it's very innocuous. It's like, changing your hair color. It really doesn't make a difference on how the virus acts. Now, it could be that eventually we'll have viruses that become less virulent or don't transmit as well. But this virus is very well adapted to us right now. So there's no pressure to really mutate into something different. A virus wants to transmit very quickly, which this one is doing. It doesn't want to make its host too sick, which is the case of this one. So it's actually super well adapted to the situation right now, a population that is completely susceptible. So we're like tinder for fire right now. So the virus is just, going through. And that's why we're doing social distancing. We're trying to cut down on the fuel for this virus so that it would peter out eventually, because it wouldn't have more hosts to infect. So we shouldn't hope that this virus in the near future will change so that eventually it will be as innocuous as the human coronaviruses that we see every season that are more cold-like. Eventually, that may happen. So if this virus sticks around for more than one season, it's very possible that it'll become one of those cold viruses, but right now that's not the case.
You mentioned Tinder, so I'm going to go back to hair color, just for some consumer information. I confess that I got my hair colored 5 days ago. Who among you would any of you go to the barber or a hairdresser at this point? Well, you're also in New York City, so maybe it's different. It's a little. I'm just curious. I'm curious. Like, what advice do you have? Would you walk into a restaurant and sit down if they allowed, 5 people 6 feet apart?
They are all closed here now, Jane. Everything is closed down except essential workers and workplaces like utilities. But restaurants are closed except for takeout. Yeah.
So in Virginia, for example, it might have changed yesterday, but we at least were allowing 10 people in a restaurant. We do have a pediatrician for a governor. Do you disagree with that, allowing that?
I do. I think certainly now, right now we have to absolutely, as Elodie stated, we have to stop the spread any way we can. And that's really to help protect our healthcare systems. So right now, for instance, I live in a high-rise building and we have about 500 people who live in this building, several elevators. I am not leaving my apartment. And we just got word that Fresh Direct, which delivers our food online, is not allowed in the building. They have to meet us at the curb and then we have to take up our supplies. They also drew a 6-foot piece of tape around the doorman. And we can't go anywhere nearer than that 6-foot barrier they've made for the doorman. They kept open the laundry rooms, but they're only one person at a time, and they've closed down the gym. So in my building in particular, on the Upper East Side in New York City, they are in lockdown and we are in lockdown. My husband and I, for instance, have made a pact. We are not going to leave the apartment for 14 days.
I hope you get along. I hadn't thought about the high-rise situation. I'd love to go back to David and anyone else that wants to jump in on this, because what you were just describing, I'm half kidding a little, about you and your husband, but loneliness is an epidemic and it's a public health problem. Ben Miller, one of the I like to talk to a lot from the Wellbeing Trust. I mean, he did something in his neighborhood in Colorado where they drew circles in the street and put chairs 6 feet apart and got together and talked. I'm planning to start something where my friends and I go for walks and we all do a conference call on our cell phones because we're 6 feet apart. How's this going to affect addiction, loneliness, mental health, suicide with all these job losses? David?
Yeah, I mean, I think this is going to be a significant issue, particularly if we have to sustain this for a period of time. I mean, one thing that we know is this is an empirical question. How long will the virus remain sort of among us in the population being transmitted? And so based on the models that we've seen so far, we can envision that it will be with us for, at least a few weeks, if not longer than that, perhaps even a few months, even potentially through the end of the summer. And so if we're considering, okay, we have to extend this period of isolation all that time, and already we're having these discussions now and we're only 1 or 2 weeks into it, how are we going to possibly sustain that over such a long period of time? This question of social isolation as a threat to our resiliency is actually a very critical one. When we think about resiliency of individuals and of communities, it's all about social cohesion, just the exact opposite of social isolation. So when you see things like in Italy where they throw open the doors and they're singing to each other down the street, and the things where you're describing ways of sort of creating some type of social cohesion, either virtually or at a distance from one another, I think those will be critical. I know just this past week, my friends and I continued our We have a little book club, journal club that we have on Friday nights, and we decided to have it virtually. And it was, you know, people are doing things like happy hours and social gatherings virtually. It's not as good as being in person, but we're going to have to become more accustomed to that sense of virtual togetherness. It does raise the question of what about those people who don't have the opportunities for those kinds of things? They don't have internet connections, they don't have the technology, or they don't have the kind of networks that are out there that would allow for that kind of cohesion or togetherness, even virtually. And this is a place where I think there are many institutions in our society that are already thinking a lot about how to handle this. Faith-based institutions, community service providers, human services organizations that are thinking about how can they still maintain those kind of human connections, even in the face of all of these isolating policies. And until we've kind of figured that one out, it's going to make the premise of remaining isolated for weeks to months a very daunting one for us.
You brought up your happy hour, and I'd never want to take that away from you. But is it okay to ask Cheryl a question? Would you be willing to answer one, Cheryl? I'm really.
Yeah, Mike, sorry.
Well, I quit drinking 27 years ago myself, and I write a lot about addiction, and leading up to the biggest stories I've done ever in my 30+ year career, although we weren't counting clicks in the 90s, were on alcohol deaths in midlife and psychosis and mental health related conditions from marijuana use. You've got California, they're letting you buy drinks to go. Essential services, liquor stores are considered essential services. I mean, would you have any thoughts on what this is going to do to our public health overall, and any concerns about addiction and suicide?
Well, I do think we've learned from the recent recession that we went through that, you know, there was an impact on life expectancy. As a matter of fact, the United States just came off of a 4-year decline in life expectancy, which previously had not happened since the Spanish flu epidemic of 1918. So that was a complicated epidemic because it was driven by opioid overdose deaths. We've also had a long-standing decline, actually, in alcohol-related deaths in the U.S., but that has been reversing for the last few years. There's a recent comprehensive article about that, I believe, in the New England Journal of Medicine just a few weeks ago. And the same also comprehensive review on suicide, which has been on the rise, particularly among people of color and youth. So we have these, you know, quote, they're called deaths of despair. But yeah. I think they're deaths of despair, but when we say that, sometimes we isolate it to the individual. And I think the way David Abramson thinks, and others on this call and yourself think, that there are social determinants that cause these problems. The opioid epidemic didn't happen without the help of the opioid industry, for example. Alcohol use in the US doesn't become an addiction for a large swath of youth without a strong marketing machine behind it for the alcohol industry. So in terms of this particular crisis, I think the point that David was making earlier, that we have to mitigate the impact of the cure of the crisis on the least among us. And this, of course, is why I think we're all riveted to the bailout package. Is it going to bail out the airlines, the big banks, and the hotels? Or is it going to make sure that people don't starve to death because they don't have any food to eat and no income coming in whatsoever because they're in the marginal economy, living paycheck to paycheck?
Thank you so much. If we could go back to, I actually saw something, somebody died just in the last day or two because they took chloroquine in hopes of preventing coronavirus. But Elodie, can you talk a little bit about like what drugs are out there, these older drugs that are being repurposed? Some people tell me, you know, they had horrible experiences with them for other conditions, and some people say, one doctor I know said he's taken one of them every time he's gone on a medical mission. So Elodie, what is there hope, or is it overhyped?
So there is hope for certain drugs. So chloroquine may not be one of those. So chloroquine is most well known because it was used as an anti-malarial, but drug resistance developed very quickly, so it's not used anymore as an anti-malarial. However, it is used in certain conditions, as in certain autoimmune diseases like lupus, for example. And it's absolutely a crucial drug for people with these conditions. And it's not actually a good drug right now for coronavirus at all. There have been tests in the lab. So they're really in cell culture. They've demonstrated that chloroquine could impact other viruses too, not just the coronavirus. It can actually impact influenza also, but that's in the lab. And that's when you're doing it in the lab, you're doing it in cells where there's availability, toxicity is not really an issue. So it's a completely different set of conditions. In humans, when even in animals, it hasn't been tested all that much. And it's unlikely to be very useful. And in fact, like you said, there was a death because somebody had seen ingredients in something they had, and I think it was in fish, poison or whatever to kill something in a fish tank. It had a mix of other things. And then also the combination that is recommended for some of the uses is hydroxychloroquine and chloroquine together. And that can have an impact on heart disease. So it's really, people do not take chloroquine. It is not indicative for this drug at all, for this disease at all. It's dangerous more than anything. And it's depleting the resources for people who actually need this drug. So that's been very distressing to watch the president trying to sell it as a beacon of hope when it really isn't. Now, there are drugs that are being repurposed. So there's a drug that was developed for Ebola, which is remdesivir. And this one has potentially more hope. It's possible that they're doing a lot of trials right now to see how well it impacts the virus. Now, in many of these drugs, you need to give the antiviral early on in the infection, because once it's in the lungs and it's destroying the lungs, then the antiviral really doesn't really help the patient during that time. And so you need anti-inflammatory type drugs that will control your immune response, which is part of the effect, the problem with the effect of the disease in the lungs. So there is some hope. I think we will know by April. So in a few weeks, we will know how well some of these drugs do work in some of these trials that are being done. So I am far more hopeful of the antivirals than the vaccines, which will not happen in the next few months. That will take a while.
The healthcare system, there's the healthcare system, of course, and the impact on the healthcare system. But just as David was addressing, and Cheryl and I we're all talking about how this could affect the real people, as we call them in journalism. It's taking an incredible toll on these doctors who are emailing me and texting and calling and social media groups. They're talking about unionizing. They're talking about just being so mentally stressed and depressed. So I wondered, Robyn, if you could talk a little bit about just from the perspective of the workers themselves and also just the overall impact on the healthcare system. And as a glass half full kind of person, I mean, can some good come out of this? Will this maybe bring more attention to infection control and just treating our workforce and the healthcare profession better?
Well, at the very least, it will bring attention to the public health sector, which has been woefully neglected for decades. It's underfunded, it's under-resourced. All of us here who conduct public health research know the difficulties we have in funding our studies. our science. But one thing that I think frightens me, and that is data that I have from earlier studies that I conducted right after anthrax, after SARS, Ebola, H1N1, and that is studies that we've conducted of what we call the essential workforce. That includes, of course, healthcare workers, but also included fire, police, prison guards, public health workers. And in all those studies across the board, no matter what decade we did them in, we found that about 50% of the frontline healthcare workers with emergency room doctors and EMTs with the highest level of willingness to report to duty, but almost everyone else in the healthcare sector, about 50%, if it was a fatal disease for which we did not have any treatment or cure or vaccine. Now, we're early days yet in this epidemic, and as Elodie alluded to, we may have at least some treatment, hopefully in the next couple of months, 3 months. They have to ramp up, obviously, production. But within those samples, for instance, police who have a legal duty, they have a mandated duty to report to duty. And now we have well over 100 policemen in New York City. We have a huge police force of about, I don't know, I think it's 30,000. So, but we have quite a few who are on home quarantine. They will report, and in our studies, about 75% said they would. But as you go down the ladder of the workforce, when you get down to, say, home health care aides, some of the very low wage paying, I already heard from my aunt out in Florida that in her nursing home, most of the aides refused to show up for duty. And now they are down to about 15 patients per aide. Some of these patients have Alzheimer's and need quite a bit of care. But even in the hospitals, I'm hearing reports not only of healthcare workers getting sick, but I'm hearing reports of nurses actually quitting because they don't have their healthcare protection. So it is definitely a concern. Maybe they will start unionizing. I know the United Nurses, I think it's called United Nurses, yeah, that union, the largest nursing union. They are very vocal, very powerful, especially out west. I would not be surprised to see much more of that organizing because they want to protect themselves, and especially their concern is to bring it, not bring it home to their families. That's their main concern.
One of the students asked, what could have been done to better prepare us for this, or prepare us so the pandemic happen, and what could be done to safeguard us in the future? Does anyone in particular, anybody that wants to jump in, Jack, any thoughts on what should have been done to prevent?
Well, I think I'm going to hand the preparedness part to David and Robyn. As far as what the lessons, I think there's some amazing lessons. I think we have a whole new appreciation of viruses and sanitation and sanitizers. And hopefully we'll probably see, I'm hoping we'll see a reduction in foodborne diseases, which very often are viral in nature. So I think our whole paradigm of sorts has shifted with this epidemic. I am embarrassed about what's going on with testing. I really believe we failed there, and hopefully that is a hard lesson. But why don't I leave it to Robyn and David too. Go ahead, David.
Right. So, you know, in the United States, there is a well-established public health emergency preparedness structure where there is funding that has come through the feds really from 9/11 on, so for the past 19 years. Unfortunately, in the last 8 to 10 years, the funding has decreased substantially. But what we really have here in the United States, and even at the international level with the global health security agenda, is we have a lot of systems in place on paper. So there's a lot that's in playbooks and operational manuals about how to surveil the population, how to respond quickly, how to detect, how to prevent, how to conduct risk communication. But these are very complex manuals. They're complex operations. If they're not exercised on a regular basis, the people who know how to do them are not practiced in them. If the political sponsorship of these activities wanes, then the degree of competency begins to decline as well. So in some ways, on paper, we're prepared. In actuality, we're finding that we're not quite as prepared as we thought we were. So a lot of it has to do with how do we sustain that level of sponsorship and investment in this public health emergency preparedness infrastructure. It's not that we don't have the people who know what to do. Unfortunately, many of them have now retired, and there isn't a continuity to sustain that.
Yes, and I'll jump in here. For many years, we had what we call pandemic coordinators at most departments of health, even smaller ones in the US. Those jobs dried up. Those people have long gone, retired, as David said. We lost institutional memory and people who really had the connections within their local infrastructure, their local jurisdiction. We've lost a lot of that. We have to change the way we're doing business in the US because this is a warning shot to us. If it's not E. coli or some other thing, a pathogen in our food chain, these complex societies we've built leave us vulnerable to massive scale outbreaks. We have to really pay much closer attention. Look, FEMA says that people should be ready for withstanding a disaster on their own for 48 hours now. Used to be 24. They were telling hospitals 96 hours. 96 hours, they were out of mass within the first 24 hours. Those precepts, those rules they're out of date. We need to revamp everything and bring us up to speed right away.
Thank you so much. I just want to remind viewers that if they have any questions, we are accepting questions, and you can just type them in and send them. We do have a few, and I'm going to get to a couple now. But please do send in any questions. We're going to 1:15. We do come back to just whether there are when we hear kind of two different things from the administration or from government officials who are speaking, whether that affects how we feel. There's of course there's a certain portion of people in the government. We haven't heard from some of them early on from CDC. I was when Nancy Messonnier said that she called her school superintendent, that made me sit up and take notice. But we're not hearing from her as much. But then on the other hand, we hear that maybe we can all go back to work. Like, is the concern, or the businesses can open? Who would like to comment on whether that is how much of an effect that could be having? And Robyn is raising her hand.
I feel very strongly about this. I've really been following the outbreaks when they first occurred in China and in Hong Kong. And as soon as they relaxed their social distancing, isolation, home quarantine, however you want to call it, they had a resurgence of cases. There are asymptomatic people that are walking around right now who may inadvertently, of course, spread it to others. So we cannot relax ourselves now. We have to be vigilant, hyper vigilant. We may have to go through this wave and into the beginning of the next wave, because as soon as we drop it down, there are hidden cases tucked away in every single community now in the US. And so we have to maintain this high level of vigilance, and business as usual might really set us back, not just with these cases, but financially, I'm hearing. So I think people who can work are now working, of course, remotely. It hurts the entire sector of service workers and gig workers, of course, and that hopefully that $1.8 or $9 trillion bailout will come hopefully directly to some of them, all of them, and healthcare and sick days and that whole 9 yards of that. But for now, we have to maintain vigilance, at least out through this entire curve and into the next. David, do you have something to add?
Thanks, Robyn. In some ways, I think we have several epidemics that we're dealing with. One is a viral epidemic, and now we're facing an epidemic of uncertainty. If it's unclear to the population who to believe or what to believe is occurring, it's going to absolutely fray the confidence in government, the confidence in health authorities, the confidence in science if we don't have a unity of purpose. I mean, you can even go back to World War II and see how Churchill essentially rallied the British population by invoking a unity of purpose. And that's what, in some ways, we need is essentially a wartime footing where people feel like this is a collective problem. This can be solved collectively. We can't start taking the scientific measures and the evidence that we have and having political leaders question it at the same time that the health authorities are promoting it. It will only sow uncertainty and then lead to people seeking other sources of information. If they're not going to believe the health authorities and the scientific authorities, well, then they'll look elsewhere and they'll find alternative streams of information, which are perhaps and most likely not valid, not reliable, or out and out disinformation. So there's a great danger in this kind of epidemic of uncertainty.
Yeah, and it seems like in so many other respects, David, that we talked about, this is coming at such a bad time because the general public is so divided on even the most basic questions that you might have thought that science proved back in the old days. Speaking of something that's just kind of a basic fact, is it true or isn't it? Because a questioner asked this, and I don't know because I have heard both sides as well. If you get coronavirus once, can you get it again? Can you become infected again?
So I can, so we actually don't know yet. So there's been some evidence that people appeared to be reinfected, but it could simply be that they never cleared the virus completely because we have seen some people shedding it for more than 30 days. So the jury is still out on this, that whether if you've had it, whether you can get it again. We don't know. We assume not, because it just seems that you would mount enough of an immune response, but we really don't know. So we can't answer that question yet.
And I don't know, Elodie, if you're the right person or who's the right person, but let's just go over one more time. Someone asked this again, and I want to be crystal clear as well. So this person wants to know, can it be passed airborne? Does it linger in the air? Because it has been reported extensively that it can linger in the air for, I think we've heard 3 hours. So whoever feels most qualified to comment on that.
Yes. So, oh, sorry, Jack, you want to go ahead? But from a virology standpoint, then I'll pass the baton to you, Jack. But from a virology standpoint, if you're in, and that's why we often hear about, oh, when the weather gets better, the virus will disappear because of heat and all that. Now, it's true for some viruses, and it's a link between temperature and humidity. So if you're in a very dry environment, for example, in a closed room in the winter with the heat blasting, when you sneeze, the virus can in fact aerosolize and go pretty far. And the study that was published on how long the virus survives on different surfaces and in the air was based on this aerosolization and being able to measure the virus for a few hours in the air. But as Jack described, when you're out in the street, and there's air circulating, you really have practically no risk of catching it from somebody else, you know, if you're beyond a distance of 6 feet. And even if you were a little closer, probably it's not a cloud of viruses. But in a closed environment where you're many people, and if there's somebody sick and they're, you know, excreting a lot of viruses because they're sneezing and it's in the air, yes, you could definitely catch it that way. Jack, I don't know what your thoughts are on that.
I just hate the thought of so many people that need to be exercising and to prevent heart disease and all the other comorbidities are sitting in their houses worried about exactly that.
Yes.
Yeah. And what we know about some of these cases where a driver took a family member to the hospital sitting in the back seat, the Westchester case in particular, how did the driver, the friend, get infected? And it could have been a cough in a small area such as a cab or a compartment of an automobile. It's enough viral particles where the person would inhale it. But it's it is an aerosol, a mist that then dries as it goes through the air and leaves fine particles in air. But again, the longevity of that is very low. As you say, the published studies are hours. So I'm not worried really about that.
But on the surfaces, there's some evidence, at least in the laboratory settings now, on surfaces, it can last seemingly quite a while. So that's this emphasis on cleaning all common use surfaces at your home or your workplace if you're an essential worker.
This next question, I'm jumping around a little bit, but hey, I'm the moderator, and this is a personal interest to Cheryl and all of us who are trying to encourage young people to get into public health. I have a daughter who's a sophomore, double major in public health and public policy. I tell her this is going to be, this field will be a hot one for a while. And one of our webinar listeners asked, will there be a surge in public health positions? Do you think there will be an increase in those interested in getting this degree working in this field? But I want to just add one more question to that. But then will these jobs dry up? Because after 9/11, there was the big infusion of funding. Will any administration have the long game continue to fund this after this, or will these public health positions go away? So good news and bad news, what do you think?
I mean, I'm happy if you want me to answer it, or anybody else, it's fine.
Anybody? I think Cheryl should start.
Well, I'll start and just say that there is a pretty well documented association between epidemics and interest in public health. So when there's a big epidemic, no matter how unfortunate it is, how fatal it is, it does produce increased interest in public health. Public health has been growing almost every year for decades in terms of the number of graduates, the number of slots in the country. Part of that is because at one time we only had about 10 schools of public health in the whole country, and now we have many, many more. We actually have 67 schools of public health at least, and many, many more public health programs. So overall, the macro trend is one of growth in public health, and part of that is very simple. The United States and many other countries, but particularly the United States, has put far too much emphasis on intervening when people are ill, as opposed to developing health and all policies approaches to keep people well. And actually, the population is the patient of people in public health. And as a nation, and in a state level, and even within corporations, it is dawning on people that they have to put more of an emphasis on primary and secondary prevention. That is stopping people from ever developing these problems, or if they do develop problems, catching them early. And that includes things like understanding what are the social circumstances that lead people to experience ill health. I'll give you a great example. Italy. When the new leadership came in, the headlines in the newspaper read, actually when they were running for office, no jabs for kids. They put in place a policy that parents no longer had to prove that their child was vaccinated to go to school. They then had a series of outbreaks all over Italy. They had a scientific report signed on to by all the leading physicians and scientists throughout the country that appealed to the government to please reverse that policy. They did reverse that policy. However, they sowed the seeds for lack of trust in public health interventions when they took that series of actions. And we are in the same situation right now. So I'm only raising that because we are creating problems that we're going to need a larger public health workforce in order to correct.
Cheryl, let me jump in. That was a great response you just gave there. And I believe I've read that one of the fastest growing undergraduate majors in the US is in public health. I could be wrong and somebody could correct me. But one of the things that David and I started about a year ago, because we realized a lot of our students were already very interested in disaster science. And we began this new certificate program. It's just starting up now. We have, I guess, 10 or 12 students enrolled in that, but we have several dozen, maybe 100 or more in our different courses. And what we started seeing last year is when it was time to place them in internships, because we had this requirement for quite a few hours of internships, we placed them in hospitals, in public health departments, in the New York City Emergency Management Department. We placed them with the fire department, the police department. they were getting these internships, and many of them were getting jobs immediately after. This is way before this pandemic. I believe that there is going to definitely be an emphasis on public health, certainly for the next maybe decade or so, and maybe even beyond that. And I think that not only public health is critical, especially for all the issues around social determinants of health, addiction, smoking, all the other chronic woes we face, but definitely a growth field is in disaster management. And that actually was one of the fastest growing job categories before this, right outside of IT, anything IT related. So I think yes, and I encourage your daughter to go forward, Jayne, and go into that field. David and I will welcome her with open arms.
I'm going to follow up on that. We have a bunch more questions, so let's try to get through a bunch of them maybe more quickly, even though I'm chatty too. Does having the seasonal flu vaccine and or 1 to 2 of the pneumonia vaccines impact your risk?
I can answer that. It does offer, because it's also flu vaccine right now, so it could make you more at risk if you get the flu. There are cases of people getting both flu and coronavirus right now. And so having had the flu vaccine could protect you of having a more severe infection.
Okay. Quickly, I happen to love this question and have some ideas for it, but I'll let David and anyone else take the bulk of it. Someone wants to help locally in their community. This person and his or her friends want to volunteer, but they know they have to keep socially distant. He or she said, is it better to stay inside? I want to say that one of the things I'm doing, I have, of course, a nonprofit where we're actually doing virtual workshops and things like that. But there are so many young people that need tutoring, that need mentoring. They all seem to have computers or phones. I mean, I certainly can connect people with young people who need those services. But David, please go ahead and suggest whatever. And we all need connection. Go ahead.
We do. We absolutely do. And I think this is an opportunity for us to exhibit pro-social behaviors, which are those behaviors that allow us to help others, which make us feel better about ourselves and help obviously reduce the isolation. There are so many community organizations and faith-based organizations that have long needed volunteer manpower and womanpower to do what they do, and this may be an ideal opportunity for people to sign on. And it could be something as simple as calling somebody else on the phone, not a video chat, but just literally the old style phone, calling and seeing how they're doing. It could even be people who are themselves ill or vulnerable or fragile at home can still be making calls to other people as well. So it gives them a sense that they are not simply left out and not a part of this, but that they also have the opportunity to be a part of a community. I think that anybody interested in doing these kinds of things should reach out to the types of places in the community that they like and would participate with anyway, and find out what can they do in these times. It could even be dropping stuff off, food, groceries, medications at the door. Obviously, the organizations that do this will have protocols for how to engage like that.
Mm-hmm. Yeah, and I think I bet you would agree, David, that one of the big problems, social media can create a lot of problems, but it also does offer there are a lot of Facebook groups for people with different types of whether they're illnesses or addictions. I just want to mention I have a Facebook group I co-moderate at USA Today, which is the biggest one. It's called I Survived It. It's all forms of trauma, mental health, addiction. And it's incredible that it's bigger than TV, sports, but these are people that have been sexually assaulted, but helping people who have lost children. So, I mean, and that is just so powerful, and I'm hoping to make it more face-to-face soon. Actually, someone asked, why are they saying blood type influences risk? I've missed that. I don't know.
I can answer that.
Okay.
So this is a study that has not been published. So there's a database where you can upload your preprints when you have a study that you think you want to submit to a journal for publication. You can upload so that people can look at it. And unfortunately, journalists tend to go through that database, and a lot of that work has not been peer reviewed. And so in fact, at NYU, we have some students who will start going through these databases to pull out papers and review them so that they can tell people what is wrong with the science or whether it's correct or not. And that particular paper was pulled out by a colleague of mine, and she redid the analyses, and it's completely flawed. It hasn't been demonstrated at all yet that there is a link between blood type and disease severity. So you can't believe that study at all. It may turn out, with a larger study, a larger trial, that there is something there, but so far there is nothing. So we have to be really careful about some of these studies that the journalists find very sensationalist and love to report on, but they have not been peer reviewed. And that's, what scientists are always scared of.
This is one of my favorite subjects, along with all my other favorite subjects, and we've been talking about doing some sort of internal webinar at USA Today on that subject, and maybe we'll get you to do it, because there is a lot of pressures in the media field right now, and that's something that, as I totally agree, is so important to resist. You can't say, I don't think any of us can repeat this, the answers to this enough. Someone asked, how important is it to get tested if you have symptoms? And of course there's how hard it is. And then this person wants to know, should we just assume that if we have symptoms, that if we have the symptoms, we have it? So just to treat it as if we are sick. And can someone please just go over the symptoms, just to remind people, because I'm asked this probably every day.
Well, I can.
Oh, sorry, go ahead.
Whoever.
So in New York City now, they have stopped the testing of the general, well or worried well, let's say. They are limiting it because they just simply ran out of more than the test kits, they ran out of manpower and lab space. They're testing only hospitalized patients and certain healthcare workers. Basically, they're saying if you have the symptoms, which are, we've seen it all, it's the cough. It kind of starts a little differently, it seems, for pretty much everyone. The dry cough and the kind of shortness, a little funny feeling in the back of your throat, aches and pains, some chills, and of course, the real important one, the fever over above 100 and for several days, and then it could get higher. They're saying to just stay at home, monitor your symptoms, call your health provider or one of the New York City's Department of Health hotlines, and then they'll direct you to what to do next. But they're trying to limit it because actually they just got overwhelmed. But one thing I just want to say about the blood, I know the blood banks are running very, very low, very low.
This very question.
So if people can please donate, if they are allowed to go out, here, even in New York, people under 70 can go out for very short walks. I don't know if they're even allowed to donate. I know that about 3% of the samples have had, I believe, Elodie, you can check me on this, 3% have corona in the blood. I have not seen anything yet about breast milk or passing the placenta. They don't believe it's happening that way. But perhaps the hospitals or the blood banks are checking the blood supply before they infuse it in someone else. But blood is becoming a real problem.
Yes, so I'm not sure about that. I was surprised to hear that they would find those viruses in the blood. It doesn't make sense, actually. So I will look into that.
Yeah.
We just have literally 2 minutes left. Why don't we just, everybody, if they could just make a quick closing comment on what the thought they want to leave the viewers with. Maybe start with you, Jack.
Yes, I'd like to comment on our risk tolerance. We see a lot of behaviors Some people think it's unreasonable, some of these risky behaviors, kids on Daytona Beach partying. We all have different risk tolerances. We collect our data. I got my hair cut the day before the barber's closed. I sized up the risk. There were two
Good,
barbers.
Jack. I feel better now.
Yes, and well, I had to do a TV appearance, so it was your fault.
Me too. That's why.
But I assess the data. This is what we do in environmental health. We assess the risks, and then we make a decision within our comfort area. Some are willing to go jogging outside without a mask. Great for them. Others want to lock themselves in the apartment for 2 weeks, whatever makes them happy. But it is, the science is very troubling because we're not factoring in the personal decision-making of that risk.
Well, I'm following whatever Dr. Fauci is saying, more so than even what CDC is saying at this point. And I believe you're right, Jack. We have to assess our own tolerance. But right now in New York City, we don't have a choice. We are pretty much on lockdown. So I'm following the people that I've been following and looking at and watching, and those are the ones I trust. And of course, my own expertise in the area.
Elodie?
So one parting thought is that when public health policy and measures work very well, the outcome is that you see nothing happens, right? So, and that's what's going on now, is that if we're doing social distancing really well, that means that nothing will happen and things will be much better. So in public health, you often lose because people who were skeptical at the beginning will say, see, nothing happened. But in fact, it's important that we do, and we have to trust the process and trust the scientists and trust the public health officials.
Okay, David?
So I'm in the middle of teaching risk communication this semester, and it's obviously the perfect time to be teaching it. And I think my comment would be that there has to be a balancing act between doing risk communication that elevates people's awareness and risk perceptions and the salience of the risk itself, but not so much so that it overwhelms them and makes them feel anxious and feeling hopeless about what they can or cannot do. And that the best way to accomplish this kind of balancing act, and it's something I referred to earlier, would be with a unity of message, so that we sort of keep a level playing field on this. We don't end up questioning, what the public health messaging would be as we're going along.
Great. That's one of my most, my very, very favorite topics. I used to talk about women driving around in the carpool on their cell phones with 7 kids in the car and talking about Zika. that you just, we don't know, we don't focus on what's most likely to hurt us. Thank you everybody so much for joining us. Cheryl, do you have anything you want to say?
I'll just close sort of where I began, that we're pressing the accelerator on mitigation strategies. And we are actually seeing early signs from Italy and signs even here that this is working. And if we take our foot off that accelerator, we will absolutely regret it.
Great. Not great, but you know what I mean. Thank you so much, everybody, for joining us today. We hope to do it again, I guess. Do we? Let's do it again.